Rome wasn't built in a day. So thank you that I can be here in this wonderful symposium among Peer and Ethel. And I'm just taking my clocks to put 15 minutes on, okay? The kitchen clocks. So I was just not prepared for very scientific talk here. So I've prepared a few reflections about what I think about the power of European networking for research in sexual violence prevention that I want to share with you. But it doesn't work. Okay, so my main aim is just to present the story of the project Paraphile we are now working on in our lab, instead of doing the basic science as we are used to. So I want to inform you what we are doing the last 2 years and to highlight the lessons we've learned, by the way, until now, because I think it might be of interest of the representative of countries where these preventative efforts are not yet developed as so much as in UK or in Germany, as you've heard from Peer and Ethel. And I just am struggling with the presentation, sorry. So how did it start? While working on the basic research on paraphilia, we were aware that there is a complete absence of targeted preventive interventions and therapeutic services for people in high risk of sexual offending in the Czech Republic, because we are a country with well-developed secondary and tertiary prevention, so services for offenders are well-developed, but nothing in a logic of prevention, early prevention, does exist. So we have first provided, because we are scientific evidence about the prevalence of individuals with paraphilic preference in the population and about their needs of care and barriers to care. And it helped us to make the arguments that the situation is not ideal. And we have suggested a solution according to the examples of the good practice from foreign countries. Some of them you've heard already in the symposium. And because we were in accordance with current European initiatives and strategic documents, we had a good luck and we got funded in 2019. And we received very great funds for 3.5 years to develop early interventions to prevent the onset of sexual offending with a special focus on individuals who are at high risk of sexual offending. So some kind of combination of sexual crime prevention and early intervention mental care. And of course, it is meant to be to provide the data about effectiveness, but I won't tell you the evaluation diagram because we don't have time for this. So what is our target group? Our target group are people with paraphilic preferences, and they are important others. Paraphilic preferences is defined by diagnostic at the time functional diagnostic manuals, those that are self-identified and yet undetected by the system for some kind of crimes, and they are important others because they create the supportive net. And we are not limited only, as many of other programs, we are not limited only to people who have sexual preference for minors, but also sexual preferences for activities including non-consent or sexualized violence. And where we are after 2 years of existence, here you can see our materials, our motto, which is you're not responsible for your feelings, you're responsible for your actions, that nicely describe the philosophy underneath and the destigmatization idea under the project, because we have to repeat again and again as an expert that paraphilic preference is not the same as sexual offendings, and the other way around, not all sexual offenders are having paraphilia. What we have done first, as I informed you, we have collected representative population and community-based data on the situation of people with paraphilic preference. These are the only data I will show you today, so just look at it because we are proud of the study that is quite rare, I would say, worldwide. But what it does show is that if you look at, for example, the preference for minors, and you count the percentages per number of inhabitants, these are quite huge numbers. And this really helps for argumentation for stakeholders that there is a lot of people in need. And more importantly, we have found that less than 15% of these individuals has experience with professional help. And if we looked more closely to the reasons why, to the communities, for example, this is the example of pedophilic community with whom we closely cooperate on. So you will see that the reasons are connected with high stigmatization of connected with this group in the population, and also with let's say expert non-competence and lack of experts in general. So there is a huge gap. So what we've done, we've created also advisory boards of stakeholders. So we've connected Ministry of Interior, Police, and Ministry of Health into one platform, which was important. But for his presentation, more importantly, we have a wonderful international advisory board or platform, including really leaders in the field from Stop It Now, Kind Thought, Verd, and Lucy Faithful, and Preventel. You can see that there is a lot of people who really were very open to help us step by step to implement what they find as examples of good practice from their own work. From training of the therapist, supervision, reviews, recruitment strategies, and so on. And it was really important. It speeded up the projects a lot. Because a lot of the problems was connected with stigmatization, we first ran several destigmatizing media campaigns, including public TV. I want to show you, so I hope you will see it. First one. Oh, sorry. So you're not responsible for your feelings, you're responsible for your actions, focused on minor attracted persons. Another one. We will help you to deal with your sexuality without causing harm to yourself and others. Focus on non-consent. And the last one. You have concerns about the sexuality of your close person. We are here for both of you. And these are very nice clips, I think. That's why I'm sharing them. We've spent a lot of time, money, and investment in these, and we are really happy we have them. And we thought it to be very good recruitment strategies, as we were advised, but actually it doesn't work like this. It doesn't bring clients, but it really helps with the opening the topic, and our stakeholders really likes it. So they are quite useful. We have also internationally trained team of clinicians by now, and we've prepared certified training for experts. You might find it really like annoying information, but it was a lot of work because and like now our clinicians are prepared to do structured diagnostic interviews, structured risk assessment, which was not applied in our country, and we don't have We don't have any standardized risk assessment measures, and this logic was not applied in crime prevention before. They are able to really use some, not, let's say, evidence-based or good practice therapeutic approaches to individually target the therapy towards increase of sexual well-being and protective factors of sexual offending of our clients, and to decrease the risk factors of sexual offending. And due to all this work beneath, we are able to go with risk need response principles that were found to be effective in previous research. So we can really distribute our efforts more to the people in a higher risk of sexual offending, and less efforts to, let's say, less risky people, which is important and cost effective. So we currently run 5 intervention modes related to project, from web pages and web counseling that are functional for a year and a half. And here you can see how many clients has already visited our web pages and web counseling. Through self-assessment platform, we've adopted Trouble Desire, but now it's not working, so no data. I present no data. And we have also a helpline, which was a reaction to the COVID pandemic, not originally planned, but of course inspired by Stop It Now, Preventel and such. And it turns out to be most popular intervention mode, where we have it's functional for 9 months, and we have more than 75 clients. And this really brings the clients to the core intervention, which is on-site or online long-term contact psychotherapeutic intervention, where we now have, after 9 years of 9 months of recruitment, around 35 stable clients in experimental group. And all these interventions are anonymous and free of charge by now. And of course, we are having evaluation design, which is not as perfect as Pierre and Ethel presented. We just have a control group, which is called treatment as usual, which has its limits. But I don't have a data, so it will be presented probably at some next occasions. But what is important, for example, for beginners in the field, and what we've learned during this application. So first take-home message is that it is doable. It is doable. We have a lot of good examples, and it is quite doable quite quickly if you have enough money and a good advisory board that will really help you. And it can really speed the start. Taken how long all the complex nets of prevention, UK, Germany were developing. They started 10, 15 years ago. So we did it quite quickly. However, the international board is very helpful, willing to help, and there is a high interest in meeting each other, which really surprised us. On the other hand, you can see that there is the destruction of the scientific efforts and innovation developments across Europe that makes, for you as a beginner, implementation decisions quite difficult, because everybody is giving their good practice advices. But as it was mentioned, you are struggling with the lack of data about effectiveness in nearly every intervention. So how can you decide then? And most importantly, data about implementation of intervention in Central, Eastern, and Southern European countries are completely lacking. So we are, let's say, one among low number of these places where we were started to do something like that. Very importantly, the data about cost effectiveness are lacking Europe-wide, which is important to press the stakeholders or to have arguments for stakeholders that you are doing something that is really important and they should support and sustain in the country. And I think we are struggling with it, all of the intervention projects you've mentioned. The grant or European grants in majority support innovations and short-term research, but long-term sustainability is a much bigger issue, which is really not very good for new prevention programs that starts in underdeveloped country in these terms, because first you have to change really a lot of things in the system. It is not about science, it's about politics and really good system adjustment. So you cannot easily start with controlled trials, randomized controlled trials. And in the starting countries, always higher kickoff costs than expected are needed because of many gaps in the system that can be discovered and needs to be fixed first. So we are very popular in the consortiums for the grants, but as countries of Central, Eastern, or Southern Europe, we are mostly perceived as a cheap country to implement something, but in fact the contrary is true, and I'm nearly in the end. And you have to also think about the prevention related tools or search tools or whatever that are not available, assessment tools that are not available in national languages. They doesn't exist. You have to standardize them. It's not only about translation, so you can't implement everything the more developed countries advise. Also, the low-cost internet-based interventions that were presented here are great, and it's very popular and promoted version. But first, there needs to be a functional net of contact intervention coordinated with healthcare, justice, and police in each country, because in the case of high-risk cases, it can make really serious problem you don't count with when you implement. So just the final slide. I think that short-time new grant scheme focused on scientific outcomes of prevention studies might be a little bit unrealistic in less developed countries. I also think that the stable European platform on research in sexual violence prevention could help first to synchronize scientific research on the effectiveness of interventions in different countries, with a special accent on involvement of Central, Southern, and Eastern Europe. And the take-home message is that European initiatives should be more synchronized, focused on dissemination towards less developed countries than on innovations in well-established ones, and to promote long-term sustainability of effective prevention systems across member countries, because Rome wasn't built in a day. It's a lot of work, of course, to develop some kind of system, but it can be really destroyed in a day. So all your investment can be lost if there is not the continuity of the efforts. And thank you so much for your attention.